Hello, everyone. We're touching today on infection prevention and control in lecture format, although you have been exposed to this in the lab, but it's never enough of how much we should be knowledgeable, evidence-based oriented, and practicing kind of even on autopilot on how to maintain our infection control practices to prevent any infection that could happen to the patient or to us, like we shared earlier in other lectures, that we're also uh, caring about ourselves, because caring starts with self. So you have to prevent infection from that is going to come to you as well. So it's always a two-way process, and your safety is always first. So knowledge comes first. We have to understand what we're doing so that we do it and we embrace it and we have that buy-in. So understand some basic knowledge about infection. Um, Infection is a a result of an invasion of pathogens, whatever those pathogens are, whether they're bacterial, viral, protozoal, fungal, they're going to cause infection, and they um, come from the pathogen and they're going to grow in a host. And then there is a differentiation between infection and colonization. And we may have touched upon this earlier, that colonization is the presence of an infectious agent within the host, but it's not reproducing in number that's enough to cause infection. But it's enough to be present there that in case that colonies are transported to another host, they can cause a pathogenic uh, um, pathogenesis in that new host. And so, what is colonization? Every, you know, how we're defined, our unit is the family, and the family is composed of this number, and then we do census to see how many population. Same thing with the pathogens, they're counted per colony. So you'll see that if you go and do a urine culture for yourself or for your patient, anybody that does a culture of a urine, for example, for E. coli's, which are the bacteria that's most guilty of causing UTIs, and you see them, they'll put there more than 100,000 CFUs or 10,000 CFUs or 50,000 CFUs. Anytime you have less than 50,000 CFUs, you're considered colonized. You just have a number of that they're not reaching to that number of bugs that can cause an infectious process. So CFUs are colony forming units. So you have to have around 100,000 colony forming units so that you can produce that infection. And I want you to understand that colonization, because you will see so many times your patients will come and be on isolation, contact isolation, because they're colonized with MRSA, methicillin-resistant Staphylococcus aureus, or VRE, vancomycin-resistant enterococcus. So you'll hear that word colonization very frequent, and it's important that you understand it. And then the other very essential part in the chain of infection is to understand the chain of infection. There's always the infectious agent, and we said there's like four major families of those. And then there's a place where they're growing because they need to grow. They need an incubation place. So it's either the food, they're growing in your food, they're in the air, they're in the water. Also, you need to think of what temperature they need, how do they survive? Are they aerobic? Are they anaerobic? Look in table 28.1 in your book, and box 28.1. So you'll see that uh, those common infectious agents. You look also on figure 28.1, and you will see the chain and how it's a circle chain, and there's an arrow. So the arrow goes from the infectious agent grows into the reservoir, then that place is maintained, and then they're living until they find a portal of exit. And then they need to have a mode of transmission to exit from one place and enter in one place. Like we want to travel to Oregon, we need a plane, versus if we're going to Chicago, we can drive. So what mode of transmission they need to use? Is it contact? Is it? And that's when we talked about transmission-based isolation precautions, because it's based on that transmission that we isolate, and we use those personal protective equipment accordingly. Then they find a portal of entry to enter into the organism, if and that host, and usually the host is us, and if that host is susceptible, that means they are in a vulnerable situation, they have comorbidities, they have an open wound. That means that the infectious agent will move from its reservoir to live now in that host. And you see the chain, as a circle, because that host becomes now the reservoir. And when we do any of those chain of infection, if we don't break them, or if we're allowing it to continue, we can change it from this susceptible host, which is now acting as a reservoir, through another portal of exit, through another mode of transmission, and have a portal of entry in another host. And that's how you are transmitting. You become the vehicle. You become that mode of transmission to the new host. And that's why we teach you how to do infection control practices to prevent any further transmission of an infection. And so that's the figure we were talking about. Okay, and we're not gonna go over quizzes in our lectures. Um, it's usually we post for you the answers, but I'd like to take a moment to think of this question. So if there would be anybody that is gonna choose any answer otherwise. So if you have a patient that has a pressure injury, and he has those vulnerabilities, Alzheimer, he's incontinent, he has Alzheimer, he's incontinent of urine, and you put a Foley in. So what is a link in the infection chain? Is it the restraint? Is it poor hand hygiene? Is it the Foley catheter bag? Is it improper positioning? And that is the Foley catheter bag. So why is it the Foley catheter bag? Because it is a reservoir. You know, it can be a portal of exit, and as well as a portal of entry for the bug. And you know, the bugs are colonizing and living in there. So you have to understand the chain of infection in order to break it and win it over. When we also talk about infectious processes, we have to understand also what are we made of. Are we that vulnerable? Because we always are depicted as vulnerable, our susceptible host. Well, we're not as vulnerable. If we're in our, we're having our defenses up, and we don't let our guard down, in the case of COVID, our face mask down, or not washing our hands, or not keeping our social distance, we're in pretty good shape, because we have normal floras, for example, that live on the skin. Why do they live on the skin? Because they're soldiers, kind of like, they occupy the land, and they don't allow other more vicious organisms to come and occupy the land. Also, you have your immune system that is ready. You have your white blood cells, from the phagocytes to the B cells and T cells, and these are very highly trained soldiers that not only can fight the enemy, but get a memory disk and put it on their backpack, so that when this enemy comes again, they identify him, and now they don't have to go through the whole process of identifying. They just, as soon as they see them, they identify them. And also we spoke about temperature and spoke about inflammation. Like And how is that related in fighting the infections? We said like the body will fight, increase the temperature so that there is that favorable environment to have the win on our side. So you'll see not only the white PCs will respond, your vascular system will respond, your immune system will respond in the inflammatory exudate with releasing histamines, with the trying to engulf the infectious agent or whatever is attacking us. And after that, automatically you'll get into the tissue repair. So we're not helpless. We have defense mechanisms in place against infection, we and our patients. So we have to invest in those and know what to do and know them. So we'll make use of them. Then we spoke about healthcare associated infections when we talked about safety, and I want to highlight it because we are guilty as charged of being some of the reasons for the healthcare associated infections. And as the name is, the game is in the name, as I always tell you, when you say healthcare associated infections, that means these infections came from a healthcare procedure. We inserted a Foley catheter and we did not follow the aseptic techniques, and the patient, we introduced a bug inside the bladder, inside the urethra to the bladder, and it may go up to the kidneys, and the patient ends up with a healthcare associated infection. You hear of the word CARI. Another thing is we might be not doing the aseptic technique when inserting a central line. We might not be doing good oral hygiene for a patient who has an endotracheal tube in, and that patient end up with a ventilator associated pneumonia. That's because we inserted that tube in. And we will learn as we grow in this profession that the longer these tubes, these invasive procedures stay in, the longer the central line stays in, the longer the endotracheal tube stays in, the longer the Foley catheter stays in, the more it is has the potential of growing bugs and increasing the chance of infection. Then you learn another thing about healthcare associated infection. That is, if you the way you give the antibiotics is going to impact how the course of infection is shortened and controlled or not. If I have a strep throat and the doctor prescribed for me Augmentin and I need to take Augmentin for 10 days, I need to take Augmentin for 10 days. Although me and you and everyone, we'll have that very bad yucky feeling when we get the strep throat, and then 3 days later on antibiotics we feel great, we're back to our normal. So guess what, we're gonna forget, or we're gonna be reluctant to continue the antibiotic, especially if it starts giving us side effects such as, then the most antibiotics tend to give diarrhea. So we stop it. What happens, that feeling of goodness that we had at the third or fourth day was because those bacteria were subdued. They were put down, but they were not killed. We need to finish the antibiotic to finish the action. So that's why it is important to go into the full cycle of antibiotic. What also transpires of that, if we prescribe too many antibiotics, the bugs, they're very smart, high order thinking organisms, I would like to say, because you see those viruses that are invisible, they're able to mutate and they were able to create new ways of fighting. So the bacteria develop resistance, the virus becomes mutated, and then those drugs that were working, they're now not working. That's where the multi-drug resistant organisms word comes from. They simply, whatever worked for the UTI is ineffective. Now we can't give, for example, rocephin for that infection. We have to give a more complex drug, a stronger drug. And with stronger drugs come the more detrimental effect on the body. So some antibiotics, they have the side effects of diarrhea. Higher antibiotics such as vancomycin has the bad effect of knocking out your kidney. So they're ototoxic, they're nephrotoxic. So you are really responsible for making sure that we don't get to MDRO's status on your patient. So we work hard to break that cycle of infection through our infection control practices. I've heard from you now multiple wisdom words of like, I can control the infection with washing hands. Excellent. I've heard also that we can control infection if we disinfect items between one patient and the other, between one procedure and the other. So all these are excellent methods of infection prevention. We're going to skip the case. So the last chain in the chain of infection was that susceptible host, vulnerable host. What could cause a person to become susceptible for infection? And you have to understand these and how if they combine together, they can make it worse or less risky for a person to contract infection. And that was very much highlighted in the COVID era, and how even Dr. Fauci, when he first spoke, and they said, why you're so afraid? And the word that kept coming and coming is that I'm not afraid for just anybody, but I'm afraid for those vulnerable people with comorbidities. And a comorbidity could be as simple as being overweight. So that was the reasoning, because there are factors that are going to affect how you contract infection, how much can you fight it and whatnot. So age, why age? There are so many things that are connected to age. Simply as we age, some of our normal defense factories atrophy. Your thymus gland, which is related to your white BCs, your lymphocytes, your T lymphocytes, it shrinks after the age of 50. On the other hand, your newborn, they're not born with all those immunoglobulins that you see. You have to give them vaccination. For the first part, they may have those transmitted from the mother, and some they drink with the colostrum through breastfeeding, but they're not well developed. Yes, you have the immune system, but it's still baby. It needs to be matured. On the other hand, your immune system will always be a baby when it comes to a new organism. And we talked about those B lymphocytes and T lymphocytes that will remember what came upon them. So the older you get, the more infections you get, the more you have in that memory. Oh, I know measles, I can fight it, and I have the immunoglobulins to fight it. And then when it comes to sex and ethnic backgrounds, and COVID transpired that very well. So, and you saw that it was affecting some gender more than a gender, some ethnic backgrounds more than other background, affected some socioeconomic statuses more than other socioeconomic statuses, correct? And in the nutritional status also it's the same. You would say guess, and that would be an educated guess, that the better nourished a patient, the more they can fight infections. And it makes sense, because all your immune system response, from your immunoglobulins to all the soldiers, you need proteins, you need good nutritional status so you can rebuild and fight. Stress is a major factor in how is our response gonna be, because stress can either physical or emotional stress is gonna be affecting the general adaptation syndrome. There's a theory behind that whenever we're faced with any threat, and infection is one of them, and we're going to have a response. Automatically, we're in that fight or flight. If we have been under stress for a long time, and that gas response has been activated once and a second and a third and a fourth time, what is going to happen to that response system? It's going to be depleted. So the more we're under stress, the more we're depleted. Now we're faced with an infection, it's going to beat us because we're drained, we're bankrupt. And also, what is my comorbidities? Is my diabetes under control? Am I in which phase of leukemia I'm in? I have autoimmune disease, I'm sorry, and I'm immunosuppressed. Am I gonna fight the same way as if I'm in the convalescent or remission phase? So this makes only sense that these factors are going to influence the infection. Imagine if you had a big, large 30% or 40% of the body with a burn versus if I have a 5% of burn on my hand. So that is going to also be impacting how I'm going to be able to control the infection and fight it off. Okay, so the nursing process. We spoke about the nursing process and we said that we're going to cover it in details and much more depth in the nursing process lecture. But this is an application of how the nursing process is applied for those patients who have infectious diseases or who contract hospital-acquired infections, and those who are vulnerable, and those who are older, whatever, all those cofactors that we spoke about, we come and look at the patient from the lens of a nurse that has that critical thinking, that has the clinical reasoning, because you're going to have to make some decision making, and your decision making have to be based on evidence-based. They have to be clinically significant. So one of the first things you're asked to do when you're assessing is look through the patient's eyes, see how the patient feels about his illness, whether it's an infection or not. And especially with illness, with infection, I mean, you need to know how much the patient knows they're at risk for infection. Some patients with infections, they may have other problems that is adding to their comorbidities, and that could and will definitely increase their susceptibility and how much that infection can take a toll on them. And then you look at the risk factors. You need to look at the patient and ask questions. How much do they know? What is the age, nutritional status? Is there any chronic illness? Is there any comorbidities, any other diseases? That will affect how much susceptible for infection they're going to be, because they're tied together. And then the next thing is like you're looking at the patient, you're assessing them, you're doing your full physical assessment, you are looking in depth at that infection. Let's suppose they have a wound, you're going to measure that wound, you're going to see how deep it is, what's the smell that is giving, is it giving any exudate, is that a sign of infection? Yes. Is it a sign of a local infection, or is it a sign of a systemic infection? Is there a difference? Yes, because increased white BCs will give you more of more of a systemic infection. High temperature, it's more of a systemic infection, versus the warmth and the swelling on the site is local signs. So you need to inspect for redness, warmth, swelling. This is all inflammation signs. A systematic, more of you're looking for fever, fatigue, nausea, malaise, presence of lymph nodes. And so all these are things that you have to be looking at. And then sometimes you need to go back and look at, is this patient on any therapies that will compromise their immune system? You have a rheumatoid arthritis patient that is getting methotrexate for the rheumatoid arthritis. But one of the side effects of this drug, or any a drug that is a chemotherapeutic in agent, let alone your patients who is post-transplant who are immunosuppressant, but some of the drugs, the regular drugs, would have immunosuppressant agent effects on them. Your steroids, if a patient has inflammatory bowel disease and they're on steroids, multiple diseases are treated by steroids, and that also has an effect on your immune system. So your defense mechanism is going to be weakened. And how do you deal with these patients? Also, when you're looking, you see them in COVID, they ask about your travel history. And before COVID, that question about travel history has been there all the time. Have you been outside the States in the last 2 weeks, in the last 1 month? Where have you been? And they look, because sometimes you present with signs and symptoms are so weird. They're not used to these infectious diseases in this area, and they look, okay, you've been in this place where malaria is abundant, and then they'll test you for that, because otherwise that it's you're not getting the full history of the patient. And then we spoke about how do we do the assessment, and that some of the lab findings are part of the assessment, because we need to see, is there an increased white PCs? Is there any culture that is positive? Is urine culture positive? Is blood culture positive? And they will make a difference in where the infection and how far the infection has gone. And remember, always when you look at lab data, you remember when I said about the colony forming units and their number, and whether we say it's colonized versus it's infected. But then there is another layer. You see, they'll check your urine culture and say, oh, it's normal perennial flora because it was contaminated because we didn't clean well. Or when they say in a urine culture staph epidermis, and they say maybe that the staph touched this, and so it's contaminated. This is another thing that you're going to hear in the infection control. So moving on to the nursing diagnosis, like a good evaluator, we're looking at the data that we have. We're looking at the cues, and we're putting the cues together to formulate, okay, what problem do I have in hand? And then you'll have specific nursing diagnoses that are only talked about in the infection realm. Same like we talked about only nursing diagnosis that we see within the safety, patient safety concept. There are certain diagnoses are in the infection concept. Risk for infection. Why risk for infection? I'll dwell only on this one, and the rest of them, it's very, very apparent of their importance. We talked about nutritional status. It's always worse when you have deficient nutritional status. If you have impaired mucous membranes, whether it's oral or in anywhere, then you have a more favorable route for entry of the organism. Social isolation is a side effect of those transmission-based isolations, or if I'm in contact isolations, or if I'm in airborne isolation, chances are my nurses and my caregivers are going to come last, so I'm going to be socially isolated. And impaired tissue integrity is, along with impaired oral mucous membranes, are going to give that route for the infection to enter. So the patient is at risk for infection with those two other existing nursing diagnoses. Risk for infection is a pure nursing diagnosis. Infection is not a nursing diagnosis. Well, because once the patient has an infection, I'll go to another layer of nursing diagnosis that I work on them. I'm not working independently on this, but risk for infection, I'm working independently to prevent this patient from getting an infection. So this is where I work on maintaining aseptic techniques, using medical asepsis, using surgical asepsis, using hand washing, using wearing the proper PPEs, cleaning the areas, using disinfectants. So there are so many independent nursing actions that I can do to prevent infection. That's why it is in here. And always, whenever we have a problem, we plan for it, we devise an action plan, and our goals and outcomes have to speak to those diagnoses. They don't come out of thin air. They should make sense. If my problem is risk for infection, my goal and outcome of this should be the patient is free from infection. Patient's able to fight that infection. The patient is understands infection. If we talk to the patient, we saw, do they understand the risk for infection? So they should talk to each other. They should mirror each other. Okay, and then always and always with nursing diagnosis, with nursing interventions, because you're pulled in multiple directions, your patient's in need of your full attention, and that patient is not your only patient. You have 4 other patients, so you have to establish priorities. You first establish priorities based on the ABCs of life, and then you base them based off of acuity. Is this acute or not acute? Then and also you base them based on Maslow's basic needs. Is this a survival mode thing, or is it just, makes them feel better? So a nursing diagnosis that is gonna keep the patient in a safe environment takes priority over a nursing diagnosis that's gonna make them feel better, like on the wellness. So preventing death is going to be your most priority, most acute patient, if that makes sense for you. So that's how you have to prioritize. You're going to do everything, but you have to say, okay, I'm doing 10 things, but which one I'm going to do first? That is going to be your battle, is to know how to set your priorities. And then, of course, you need to know that you rarely are going to be able to accomplish all your goals or outcomes without teamwork and collaboration. And with teamwork and collaboration comes effective communication. And with teamwork and collaboration comes the knowledge that the patient is the front and center. Nothing about me without me. And if you want to get to be successful, you have to incorporate my caregiver, my significant other, my family, and have a good communication to the whole team, so everybody's on the same page and not things are not being redundant and repeated, and we're building out of the successes of other team members. Implementation. We spoke about what are our main problems when it comes to infection, and so you need to first and foremost prevent that infection from spreading. Okay, because you have to keep in mind that other people, you're going to have, instead of 1 down, 2 down, or 3 down, and that's going to be an additional burden to your limited resources. So front and center is that patient education of how to prevent infection, how to wash hands, how to wear PPEs, how to dispose of infected materials. And also incorporate in that the patient's cultural and ethnic backgrounds and their habits. So take that into consideration. Nutrition, you have to assess the nutritional status of the patient based on your physical and history assessment, and then you ask the patient how much they know, what do they know about nutrition, and then always that teach back moment. Okay, you taught them about it's good to take fruits, it's good to take vegetables, you need to get those lean meats, you need to have high protein diet, low fat diet. You always have to check, did the patient understand what you're talking about? So you pull that menu from the hospital, say, okay, can you show me a meal plan that you're gonna get for lunch that is nutritional, of nutritional value, based on your wound infection need. Makes sense? Then hygiene, we clean, we try to disinfect area, we try to do all those infection control measures, but we're forgetting that the patient is part of the formula here. I've seen places where they have that Purell at the bedside of the patient, so that the patient who's using the urinal at the bedside and their mobility is limited can't go to the wash basin, to the basin, to the bathroom to wash their hands, they'll use the hand sanitizer at least. Another layer of making sure that you're taking care of the infection control, from health promotion, from keeping it at a good stand when we're fighting infection with, and we have all the odds at our side, is keeping up with immunization, making sure that our patient has their flu shot this season, because it's going to be double trouble if they get the flu with the coronavirus, and that is going to be a challenge for you all the time. Immunization, usually patients don't want to get immunized when they're sick in the hospital, but the CDC recommends that you get the vaccines against all those potentially serious illnesses, and then you reduce the burden on the community. Rest, adequate rest, regular exercise. I can't stress those enough. You've been there, you've done that, you know how rest is rejuvenating for you, so it's going to be rejuvenating for your patients, going to give them the amp to fight the infection. And stress, we talked about it and how it impacts your fighting the infection, so all those just make sense, correct? And in the acute care, we're going at a higher level of fighting that infection, knowing that we're now past that. I'm gonna do the health promotion. I need to really save that life, and get rid of that infectious disease, infectious organism, to prevent further deterioration. So first and foremost was medical asepsis. We go back to those cleaning and disinfecting and sterilization. So just know that there is a continuum. It's a linear continuum. The item is contaminated. The first thing you have to do is clean it. So cleaning comes before the second step. You can't disinfect something that is not clean, because the disinfectant has to touch skin to skin with the surface without any layer in between them. That's why you couldn't wash your hands with an alcohol rub when they had soil on them, whether that is dirt or anything. It is gonna form a layer in between the surface that you're disinfecting and the disinfectant agent that you're putting. So you need to understand that. So you wash that area, you wash your hands till they're clean, and then you apply the disinfectant. And there is a theory behind disinfectant as well. You have to have enough disinfectant to that surface area. So the proportion of how much I'm putting in one, I'm pressing the pump once, that is enough for an average hand. Okay, it's gonna be enough to disinfect my hand. And then you learn that you need to rub for at least 15 to 20 seconds. So that is the exposure time, and it is a very important element in the formula of disinfection. So first clean, then disinfect appropriately using all the appropriate measures. You're gonna see in your learning that there is a low disinfectant, high disinfectant. Then you're gonna go to sterilization. Okay, sterilization is the absence of any organism on a surface, whether it's your hand or it's the table. Correct? No, wrong, because you can never sterilize your hand. Any living organism, you can't sterilize them. Any hard, inanimate object, you can sterilize. And that also is not a acceptable sterilization, because there are inanimate objects that you cannot sterilize, because there's a couple of methods of sterilization. You either sterilize through the heat mechanism or through gas mechanism, so you put them through these processes of sterilization, and you have some material that's going to be destroyed through the process of sterilization. You would wish that you can sterilize it, but you cannot. That's why you resort to the high disinfectant. You'll see those endoscopes that they put in the patient, and they're made of certain material. When they're doing a gastroscopy or endoscopy, they cannot disinfect them. Some of them cannot be disinfected. I'm sorry, they cannot be sterilized. So they will clean them very well and then disinfect them, and that will definitely reduce the viral load to 0. Those high disinfectant agents are very potent, and they will really disinfect. But we can't say it's something that's highly disinfected that it's sterile. Sterile is just the item that has been through sterilization. The next level of protection and that is element of medical asepsis is protecting your patient, and that is through, you have a nice box on 28.9 about how do you protect your susceptible host. And those of you who have worked in the healthcare field, they've seen how you've been instructed to use a chlorhexidine bath. And so what does that do? Is that, okay, I am sitting in bed and I have an open wound or a portal of entry, an invasive procedure, a central line, and my organisms walk. They like to go on walks, and go places they shouldn't be, and they'll walk and enter through that portal of entry, because they have a portal of entry. What do? You wash that patient with chlorhexidine bath to reduce the organism's load. The patient is cleaner. They're not disinfected, high disinfection, but they're clean and they may be mildly disinfected. That's why you use those chlorhexidine baths. So if you can understand this, and like the medical asepsis process goes through those chain of infection. So you either are working on protecting the host, or you're working on eliminating those entry portals, or you're working on the exit portal. So one exit portal is you sneezing in my face, so use the cough etiquette, versus the entry portal, me not putting a Foley in you would control for the entry. And of course, the biggest gun that we can use is hand hygiene. Believe it or not, hand hygiene is the single most effective measure in preventing transmission of infection. Studies support what I'm saying. Are we doing a good job about it? No, we're not. If I ask you what is the compliance rate of hand hygiene among healthcare providers, you may give me a number and I will tell you you're far off. The latest number in compliance in hand hygiene, which should be, according to one of my students, my beloved student, 100%. I said, yeah, we wish, but it's not. It's not even half. It's 48%. And when do you need to wash your hands to control infection as a measure of medical asepsis for a patient? Is when you get into that patient room. Of course, you're washing your hands when you're going out of that patient room to control infection coming to you and to control infection going to another patient. So studies, those same studies that found out that we only wash our hands 48% of the time, found that we wash our hands less when we're coming in and more when we're coming out. Then comes your isolation precaution. And yes, you need to understand those isolation precautions. They discussed them in your lab, and they're gonna come to you again and again. And whenever you cover a material, we're going to be responsible for it, because now we have to integrate it within our practice and we have to have it as our second nature. Standard precautions is the golden rule. What does standard precautions mean? You put an equal sign near this. Standard precaution equal every patient is infected. Every patient has the hepatitis B virus. So I have to wear gloves every time I'm touching that patient's blood or patient's fluid, irrespective of what's fluid. There's a joke that the dean always says, if it's wet and it's not yours, wear gloves. So that could be something that you can remember. Standard precautions, it means standard across the board. You do it with every person. Transmission-based precaution is what is the game is in the name. You base your precaution based off of what mode of transmission that disease is. So we come to COVID and they found out that COVID, it's not only droplet, it's more. So we're using more of the airborne transmission-based precautions with COVID. What is the difference between them is their mode of transmission. Contact means if I touch the organism and it's on my hand, it's on my gown, it's on my stethoscope, it touched. Contact is in touch. Whatever touched one place and went and touched another place, before it has been cleaned and disinfected, it's gonna lay those organisms that I collected with that touch, with that contact, whether it's direct or indirect, to the other place. Droplet is anything that goes through the air, but droplet means that it is a little bit bigger. It's going through the air, but it can't travel too much. It's so fat and heavy, it drops. And that happens with any organisms that is more than 5 microns. So it drops on its way. Usually it drops within 6 feet. Thus, that 6 feet, the 2 meter, 6 feet rule. But then there are some microorganisms that will go through the air, and they're light and they'll go through the air. That is your TB bug. It is so light, it's less than 5 microns, it will travel up to 25 feet. So that's why you have that patient in a room by themselves. Also, because it travels, they'll put that patient in a negative pressure room where the air is sucked in from this room and not allowed to go outside into the hallway to other rooms. It goes right outside. Versus you see here protective environment, and that is when you protect your vulnerable immunocompromised patient from the environment. So you put them in a positive pressure room where their air can go out to the hallway, but the air from the hallway can't come to them. That's one of them. Personal protective equipment, gowns, masks, eye protection, gloves, these are the general ones. Face shields is in fashion nowadays with COVID. Everybody knows face shields. So, but the sequence of wearing your protective equipment is going to be of essence in how you're controlling infection spread. So, you have to know how to don your gloves, to don your protective equipment, which order you do that, which order you take them out. And you've had that practice. You have a beautiful box, box 2812, box 2813, that it shows you how you do this. You have wonderful videos from the CDC that also explain this. There's tons of information now, so there's no room for permission for not performing this task to perfection. And then with this comes that fact that patient is in isolation. They're gonna have psychological effects. Your family is not gonna visit them as much. The staff is not gonna go into as much. So you have to put that into consideration. Then comes another layer. What if I have to take this patient to a procedure? What do I do? And then so you need to understand and learn how, when you're transporting patient with a droplet or airborne infection problem, you need to put a mask on them so that they're not spreading it. You saw when you're transporting a patient with contact isolation, you dress up, and then you have to also keep in mind that you have to be able to keep that same level of transmission-based precaution anywhere the patient is. And you call the unit where you're going and you say what type of isolation you have the patient on. Make sense? The way you deal with the bags of trash or the bag of linen is also part of your infection process and your isolation precaution techniques. Specimen collection, you have to deal with them same like the standard precaution. I'm collecting the specimen. In addition to wearing and the proper PPEs, I have to deal with those specimen in that same level of precaution. Next is going to be your in every institution, there are infection control professionals, infection control nurse or officer or specialist that are there to help you, whether education-wise, whether evaluating what type of disinfectant we use, whether we have the procedures in place, whether we're doing good antimicrobial management, how is the pattern of infection is. So they collect, analyze that, and they do some epidemiological studies on the infection. They'll help you and they'll come educate you and help you, and they're your resource for that matter. So when it comes also again to infection control, you see that they talk about WHO's 5 moments. There's 5 moments of when you should clean your hands. If you remember those, you'll always be good. So there's 2 befores and 3 afters. Before touching a patient and before cleaning or doing aseptic techniques, before doing a clean aseptic technique. So you always wash your hands before you do those. And after touching a patient, after touching the patient environment, and after exposure to any fluid, body or blood fluid. So these are 5 moments. If you remember them, you're good. Then there's another layer, okay, is exposure. What if I get exposed? So there is post-exposure prophylaxis. You're gonna see that you're gonna have to fill an incident report, and whether it's a needle stick or you just got exposed to an airborne disease, you have to have that post-exposure follow-up. And these are the 5 moments of hand hygiene. Surgical asepsis is the next gun, the bigger gun, where we are making sure that we're following sterile procedures. I'm not gonna be going through these. You need to know them by without fall. Just know there's like at least 7 rules of surgical asepsis. If you turn your face away from it, it's not aseptic anymore. The outer 1 inch is always infected. If it's less than your waist level, it's not sterile anymore. So you keep those. You don't cross your sterile field. Keep those in mind. How do you wear your PPEs in a surgical asepsis? What things you pour first? If the sterile field is wet, is it still sterile? So all these you have to know them. I know that you have details of those, and we're gonna be learning the surgical aseptic techniques and getting trained on them as much as we got over medical asepsis. And last but not least in our process is we always evaluate. And so remember how you started with seeing things through the eyes of the patient. You always, when you evaluate, you have to come back and ask your patient whether what they expected or they wanted is mapped. You know, the patient need to understand whether things are working or not working, and then they'll be compliant. You know, and always compare what you actually had to what you expected. And when your goals are not achieved, you go back and reevaluate your process and say, okay, this did not work. How am I gonna achieve my goals best, and what are my next steps moving forward, you know? Safety guidelines for infection control practices. As I said, always apply standard precautions. Anytime you have an anticipated contact with body fluids or blood or non-intact skins or mucous membranes of another person, use clean gloves. That's medical asepsis. When there is a risk for splash, wear your gown, wear your mask, wear your eye protection or your face shield. Keep the area clean and dry. When you're doing any aseptic procedure, follow the surgical asepsis rules. After you finish, if equipments are disposable, get rid of them in the proper container, sharps in the sharp box, and so on. And if it's a shared equipment, you need to clean it immediately. Make sure you know how to clean. For example, in the units you have, and if you're in Beaumont, for example, you have those disinfecting wipes. Some are purple on top. These are for all surfaces, general surfaces, versus if your patient has a C. diff, Clostridium difficile, but you need to use the one with the orange top that is more of hypochlorite base, and then it cleans better, cleans. It is the efficient way to disinfect C. diff contaminated area. So always clean your stethoscope between patients, clean the vital signs between patients, use dedicated equipment for patients who are in isolation. And along that line comes your role as an educator for your patient, as an educator for your team members. So your unlicensed assistive personnel, your UAP, is your responsibility. So you need to make sure that when they're going into isolation room, they don't take an equipment and go out and share it with other patients. You are the teacher for those who are in your team. Teach the basic etiquettes of infection prevention spread, keeping the face mask on, using how do you cough, how do you sneeze if you don't have a tissue, and so on. So your role is very important, and you really act as a team leader. That's what you're gonna end up being, a team leader. You have a very nice box uh, in your book, chapter in chapter 28 on page 450 up to 460. No, actually, to up to 463. And these are around how do you wear your surgical attires, and how do you maintain your surgical field. So read them, read the rationales, also watch the videos. You training and repetitive deliberate training, the repetitive deliberate practice will make perfect. Of course, while you know what you're doing and you're seeing what's the rationale for when I do this exact action. And with that, I will leave you, and thank you for listening. Have a great day.